Our next speaker is Dr. Arthur Felice. He's the president of the UMS Division of General Surgery, senior lecturer in surgery, University of Malta, and board member of the European Society of Surgery. He'll be talking about thought processes and decision making in GI and other surgeries. Please welcome Dr. Arthur.
I think we all agree that decision-making in surgery is very important, that thought processes are an important aspect of it. Clinical decisions are mostly inherently uncertain, based on estimates of probabilities and balancing trade-offs. What's more, it's done in a situation of time constraints, high risk, and limited data. There are 4 phases in surgical decision-making: data collection, which defines the problem; data analysis, which specifies alternative actions; the decision, considering possible outcomes; and eventually, review and reassessment. This is done in varying sequences. The trade-offs which we spoke about involve accuracy and a safe time frame. We would all like to do optimal decisions, like application of statistical decision rule to data, as in mathematics. But in fact, in medical practice, this is rare. Most of our decisions are suboptimal based on probabilities, close calls, balancing trade-offs. When a surgeon's making a decision during surgery, as we said, he is governed by time constraints, degree of risk, and limited data. And there is a whole spectrum from, at one end, a high-risk, little-time situation to a variable risk, more-time situation. And the decision-making strategy goes accordingly. So if you have one end of the spectrum, your decisions are maybe mainly intuitive, recognition primed. As you go along to the other end of the spectrum, you have a rule-based decision, and then more time, and analytical decision comparing different options. Eventually, when you have plenty of time, you may be even creative, designing new options as the situation, when the situation is unfamiliar. After the decision, the review and assessment stage is imperative. Risk-taking is part of the decision-making process. It may be active, making a choice with the greatest outcome variance, positive or negative, or it may be passive, foregoing an opportunity to act in order to reduce outcome variance, like masterly inactivity and so on. The risk is identified, evaluated, patient is treated, monitored, and one then moves on from their cycle again. Risk assessment and tolerance is influenced by personality, correlates with age, and risk-averse attitudes correlate with the use of additional resources to avoid uncertain outcomes. In dealing with risk, we must know what to expect, understand the risk, and have good communication and relationship with the patient. We come to clinical reasoning from a theoretical aspect. We have this involves knowledge, experience, and rules of logic. And knowledge is based on basic sciences, clinical science, appraises research evidence, and also knowledge of rules of logic, of fallacies. Our papers, not our papers here, but in general, medical journals are full of fallacies and biases, and a good, very, very large proportion of them can be thrown out of the window anytime. So knowledge is eventually learned, organized in memory, and access to solve problems. We come to experience. We all know that with more experience, you tend to make better decisions, but this has been proved experimentally. I have here the results of one of the very first controlled trials to prove this, and they pitted cardiologists against physicians as to the correct interpretation of auscultatory findings, and obviously the cardiologists won the game. Now, what forms of clinical reasoning do we use? We use logical reasoning, discursive that is, and this may be theoretical reasoning, the classical inductive, deductive, or hypothetical deductive reasoning. This leads to, or is supposed to lead, but should, to certain conclusions. Then there is practical reasoning, which was forgotten by logicians and philosophers for many, many centuries, but in fact is an old concept because it was Aristotle who proposed it in the first place. It is not meant to lead to a certain conclusion, but it's meant to lead to the best possible action. Then we have also intuitive reasoning. Here we have a lot of confusion, and the reason is that the definitions of the terms used in by the people who are doing this kind of research is not accepted properly by everybody. So people tend to talk at cross purposes, and as an example, they refer to intuition when many times what they mean are subconscious algorithms. Somebody will object that with so much IT around, we shouldn't be talking about the processes of the mind. Well, we have this slide which can analyze that objection. On the left, we have a column with computer applications that we use in clinical medicine. We use digital circuits, logic programming, databases, artificial intelligence, algorithms, artificial neural networks. Each of these has got a mathematical symbolic logic process inside it. That's how it works. And each of these symbolic logic types has got the corresponding philosophical logic counterpart. So really, logic is very, very important. What influence decision making? Evidence, values, circumstances, and bias. Some considerations. First, the complexity of disease. To counter this, we have to develop interfaces for interprofessional teamwork. We also need feedback to improve design systems. In decisions regarding treatment, one has to identify the ultimate objectives, such as cure, palliation, symptomatic relief, etc. Select the treatment and specify treatment targets, that is, when to stop or change course. There are also constraints on policy decisions, such as rising standards of care, improving equity, and economic constraints. Because of the complexity of the problem, it's no wonder that there are many aids have been proposed to aid clinical decision-making, such as multivariate equations and analysis, decision analysis, clinical problem analysis, mechanistic case diagramming, the clinical algorithm, guidelines, computerized guidelines, scoring systems, information technology, and artificial intelligence. Each of this has got its applications, but also its limitations. We'll just skim through this, because otherwise it would be a long discussion. But multivariate equations allow simultaneous considerations of multiple factors, where each relevant variable is weighted differently. In other words, they have different utilities. This involves complex mathematics and IT, and is not very well adapted to the bedside management. Multivariate analysis can evaluate information consistently and quantitatively and may lead to better use of resources, but the patient may be different from the ones used in the model, and variables may be poorly defined or selected. Also, the weighting, the utilities that we mentioned, is subjective. Decision analysis is quite interesting in that it's graphic. It's a graphic representation of decision trees. This one is investigating the problem of exploring or otherwise the common bile duct during cholecystectomy. And one draws the expected utilities against probability of stone. You will notice that in the graph referring to common bile duct exploration, with increasing probability of stone, the graph is decreasing. And the reason is that though you're doing the right thing in exploring the common bile duct with increased probability of stone, but having the stone in the common bile duct is a disadvantage. In other words, the utilities are less. Clinical problem analysis is a systematic way of resolving a clinical problem in its entirety, tackling it in terms of pathophysiology and anatomy. It is often expressed as a mechanistic case diagram. This is an example of such a mechanistic case diagram in the case of intestinal obstruction. From it, you can deduce symptoms, signs, investigations, and even therapy. And it's a good way for teaching students about a subject, summarizing it. Algorithms. Algorithms have become quite popular now. They are a relatively recent addition to the armamentarium. The first algorithm was proposed in Yale University in 1974, so it's not so long ago. Most of the time, they look complicated. Some look more complicated than others. In fact, they are not complicated at all because they are just a graphic representation of what the author or what an experienced clinician would do. And once even you master it, if you haven't done it yourself, it comes natural and you don't have to look at the algorithm, it comes naturally. Algorithms are useful as effective education tools for clinicians and patients to improve patient care, reduce costs of care. Their limitations is that they are difficult to apply to very complex clinical problems. All variables are weighted equally. They do not consider interactions between factors, are deterministic, and do not indicate the level of confidence of the recommendations. As everything else, they are author-dependent. Everything else in life, not only in medicine. So I think the last comment is superfluous. Guidelines, they feature decision points, evidence is necessary, and they must have an applicable layout. Computerized guidelines are accessible references, show errors, improve clarity, are adaptable to particular clinical states, propose decision support, and some even send reminders. Scoring systems, these are most interesting in that they are very, very simple and also simple to apply, and they are yet quite accurate. Their results compare well with much more complex systems such as artificial neural networks, and I couldn't understand that for a long time until I got to know that scoring systems are derived directly from artificial neural networks, so no wonder they have parallel results. Their usefulness is for indications, grading severity, prioritizing, helping in audit and research. Their limitation is that they do not consider urgency. Urgency is not priority, okay? And they do not consider the efficacy of the procedure. We come to information technology and artificial intelligence. Here we're talking about IT, mathematical processes, and artificial neural networks. Actually, artificial neural networks include the first two, 1 and 2. And you have an input process linked to a hidden process by those several arrows, each of which has a utility. And then this is linked to an output process, again linked with arrows, each of which carries utilities. Now, if you analyze the result of the output for correctness, whether it's correct or not, and you feed it back into the input, and you do this repeatedly, the utilities are every time changed by the system itself. Thus, with changing utilities, with the corrections, the machine actually learns. So what is the use with so much technology to talk about the brain? This slide tries to analyze this. Well, the brain has 1 trillion cells with 1,000 trillion connections. The supercomputer has 1 million silicon neurons only. The brain learns more easily and faster, and the supercomputer can tackle many tasks concurrently with greater ease and faster. The brain uses logic, but is influenced by emotion, whereas the supercomputer uses logic only. And the brain is better at interpreting the outside world, new ideas and imagination. The supercomputer is faster at logical computing. Thus, it is not appropriate to try to say which is the superior method. They have different attributes and are actually, therefore, complementary rather than competitive. Ackerman, who was one of the foremost pathologists in the USA until a few decades ago, said, "A good surgeon has not only technical dexterity, which is a fairly common commodity, but also, more importantly, good judgment and a personal concern for his patient's welfare. The surgeon with a prepared mind and a clear concept of pathology of disease invariably is one with a good judgment." We therefore conclude that decision-making aids may help, but do not replace clinical judgment based on knowledge, experience, reasoning, and also hard work.
Thank you, Dr. Arthur, for this interesting presentation. Any questions from the audience? Actually, I have a question for you, Dr. Arthur. What sort of advice would you give for young surgeons, who might be influenced or affected by their decisions in emergency situations, like, in the ER, trauma patients, a lot of physicians around, anesthesia and ER might push him to take to the OR, they might influence this decision. What kind of advice you might give to such young surgeons? Thank you.
The advice I would give would be that they have some idea of the logical processes that they are involved in. And in fact, the advice should not go to them, but to people who prepare their syllabus and their curriculum. Because in any medical school, practically, they do not teach them how to think. They teach them everything, but not how to think. And when it is such a basic thing, and this is a great lacuna in medical education, both at undergraduate level and at postgraduate level. If you look at the papers that are published in the journals, reputable journals, over 90% have either something which is completely illogical in them or are influenced by biases, because people don't know the logical processes, don't realize they're making mistakes. For example, there's a common thing. They associate something with another and attribute a cause. Very common. Rubbish. You can't prove anything like that. But this can be applied to clinical practice, in fact. And there would be far less decisions if people are aware how they are thinking. We do not teach them that, and the advice should go to their superiors.